Our whole approach to the support of especially premature babies, and to some extent the term babies, has been, if you like, influenced by the effects of what we've done in the past. And we've learned from the past, we've learned these lessons sometimes painfully over the past maybe 3 decades, that while we provide various kinds of support for small babies, such as putting tubes in their windpipes, putting them on ventilators, providing that kind of support, that kind of care that we give them while supporting those children also comes at a high cost with morbidities and problems associated with it. Some of these are technically difficult. Some of them are associated with complications that are worrisome. And so the whole approach to care for these small babies has been to try to move away from those aspects of our care that we think are more invasive and where we found alternatives that we could treat the baby with. So the last, I would say, especially 15 years, maybe 10 years, there's been a search for, an aggressive search, to find ways that we could treat these children without having to be invasive. And I would say, you know, what is invasive? I think, to me, when I think about invasive and the respiratory support of these small babies, invasive usually means to me that we've had to put an endotracheal tube in the baby and usually use a ventilator for those children. And you know, the other thing to remember is when surfactant came along, and it's now been with us blessedly for, you know, almost 20 years, that surfactant, in the way we give it, required that we had a tube in the windpipe. So here we had a therapy that has been shown to reduce early, you know, death and complications and morbidity in these children, but it required that we are, if you like, invasive. So the question now is, can we get away from that and still give the kids the benefit of that therapy? And that's where we've been searching for. And that's sort of been maybe the holy grail in respiratory support for the last 10 or 20 years.